Good morning. I want to make one announcement before I introduce today's speaker. We've been busy trying to get everybody's oral presentations scheduled. We have some challenges with the time, particularly since we have a really big group this year. And as you know, we added some extra days. We actually ran out of extra days we could add, and so on June 18th, we're going to need to see if we can identify people who can stay longer. We should be done by around 11:45 that day. We don't expect all the participants to hang around for that, but I ask you to work with us to try to find times for people who can fit those slots so that everybody gets a chance to present. We should have a first draft of the schedule ready to send out by the end of the day today. And if you get a slot so I was able to give about 70% of people their first or second choices. Probably the other 20% of the people got something that was blank on their matrix of times that were listed as available. And I assumed that if you didn't say unavailable, that blank meant it could work, but it wasn't too great. I'm sorry about that, but we tried to do it in a way that accommodated the people who had very limited times they could present, and then to be sort of relatively random after that. So let us know if what we've assigned you just doesn't work. Our experience is that we generally don't get more than 10 minutes behind on the schedule, so you can be pretty sure that your time will be within the time you're supposed to start. We rarely get ahead of schedule, but you rarely get more than 10 minutes behind, so you'll know roughly what the time commitment is for you. We would love it if people can come to the extra Tuesday and Thursday. We have actually one Monday, some Tuesday and Thursday morning sessions. You can use those sessions to make up any time that you may need to make up for your getting your certificate. It's not absolutely required, but it gives you a chance to, first of all, hear about what your peers are doing, show some respect to your peers for the work they're doing, and also get more experience in giving feedback to your peers. So hope you'll come to as many as you can. Okay, so today our speaker is Dr. Ken Sagg, who's a professor in the Department of Medicine in the Division of Clinical Immunology and Rheumatology. He also has an appointment in the Department of Epidemiology in the School of Public Health. He's vice chair for research in this Department of Medicine. He is a very dedicated educator. He's the director of the Center for Outcomes and Effectiveness Research and Education, which has traditionally had both a K and a T program. I'm not sure exactly what its repertoire is at the moment, but he's also the director of the KL2 program and the TL1 programs for the CCTS, and is very dedicated to career development of early career physician scientists and PhD scientists. And his research has focused on osteoporosis and some autoimmune diseases, particularly rheumatoid arthritis. He's very well-versed in how to get the most out of research, trying to identify the best outcomes for the therapies that we currently are authorized to use, and to give feedback on how things are actually playing out in the community. And he's going to talk today on health services research, outcomes, and community-based participatory research.
Well, David, thanks very much. Good morning. So, yeah, David has given the title, and there's some synonyms, more or less: health services research, comparative effectiveness research, patient-centered outcomes research. For today's purposes, these things are fairly similar. There's been some shifts over time in what we sort of call this broad area. Some of it's been a little bit political, some of it's been a recognition that we really ought to be engaging patients in what we do, and so on and so forth. So I'm going to give examples today from this broad area, and since I'm a rheumatologist, most of the examples will be in rheumatology, but I think they'll have broad applicability to the field and hopefully be illustrative of the kinds of things, the types of studies that we classify in this broad spectrum of research. And so I'll talk about large database work, pharmacoepidemiology. I want to, if you haven't been introduced to it before, I want to talk about pragmatic clinical trials, which have really gained some traction, and a little bit about implementation science. Now, how many in the room would classify themselves as a translational researcher? We've got a couple hands, and of those who put themselves in that bucket, where would you say you fit? Would you fit early translational phase, later translational phase? Early, T1, bench to bedside, later, from bedside into the community. So this is kind of the spectrum. And normally when we think about translational research, we're usually back in here, thinking about taking a discovery and trying to develop a human next step, be it a therapeutic or some sort of a practical application of a in vitro or lab-based finding. What we're going to talk about today is really moving over into the translational spectrum of proof and practice. And that's really where this area of health services research comes in. And it sort of bridges epidemiology, public health, and bioethics. Now, I've already alluded to this slight quagmire, that is the names changed to protect the innocent, so to speak. And we had some money back, what I guess now nearly 10 years ago, with the stimulus, with a spending program from the government that was targeted to comparative effectiveness research. Then there were some political pressures and concerns that some of that money was being used to try to extinguish various healthcare services, and so that became a little bit of a dirty word, particularly if it had anything to do with cost research. And then along came patient-centered outcomes research, PCOR. One of the things that drove PCOR was PCOR-E. PCOR-E is the Patient-Centered Outcomes Research Institute. And this was established with the Affordable Health Care Act to basically provide a new source of funding for this research. It's a dollar tax. Anytime somebody purchases insurance, be it private or public insurance, a dollar goes into a trust fund that is used to fund this. And you can see that at its peak, there's about $500 million a year of money to support this sort of research. Now, think about this in the context of another agency called the Agency for Healthcare Research and Quality, or AHRQ, which is also under Health and Human Services. It's kind of the poor sister to the NIH. They have about half that budget. So this is a lot of money for this type of research. Now, interestingly, we're not really sure where this is going. It hasn't been reauthorized, and it's not clear whether PCOR-E will continue to exist or not. But it has had some impact, and there's been a number of investigators here at UAB that have directly benefited from this. We benefited from it quite a bit directly because some of this money that's been allocated through the Agency for Healthcare Research and Quality is going to support training. And so, as David suggested, we've had a K-12 and patient-centered outcomes research. We've had a previous predecessor to that in comparative effectiveness research, and some of our money in our current T32 in health services research is also originating from PCOR-E. Another thing that has really been pivotal and is certainly the national trend is the idea of trying to combine systems, trying to combine data across centers. And CoreNet was established to do that. CoreNet consists of clinical data research networks and patient-centered research networks, CDRNs and PPRNs. UAB actually is one of the PPRNs. My colleague Jeff Curtis in rheumatology has a patient-powered research network, and that's supported through PCOR-E. His is actually a collaboration with a group called Creaky Joints. It's an online group that people go to talk about their arthritis symptoms, and the idea is to harness the power of all that social media activity to try to collect data and to do research with this community. Now, this group, actually, PCORnet, has taken on a life of its own. They've actually spun off from PCORI, recognizing that PCORI may end, and they've created a private entity that is now bringing these large databases together. But the idea is great. It's to get electronic health data across multiple institutions to talk to one another. UAB's been involved to some degree. We've been involved through an I2B2 platform, and we're trying to really get more into the game, but it's really just in the last 5 years or so that we've really been able to use our data within our health system. We collect all this tremendous clinical information within our Cerner EHR instance here, but we haven't really had good access to that really for only in the last 5 years. So we're not part of the clinical data research network. We're part of the patient-powered research network, and ultimately we'd like to be more engaged in this. The other thing that's been going on concurrently is that the network of CTSAs, these are these large NIH-funded centers. UAB is one. There's about, I think, what are there, 40, David, or 60 others? 60 altogether. All the major academic medical centers in the country have this support from the NCATS, one of the NIH institutes, and they've created TINs and RICs. RIC is a research innovation center. TIN is a trial innovation network. It's the same idea. How do we get data sets working together across large institutions? We'll talk more about the value of some of this data, at least as it relates to billing claims, but having the actual real clinical data from electronic health records, even better yet, having it in a way we can use it is tremendously valuable. All right, so I'm going to focus on a few of these topics, and I want to also show you this, because I think this is a really helpful framework for thinking about just how research fits together. So most of the time when we think about doing research, we're over here. We're generating evidence. We're doing observational studies or interventional studies. We're doing, if you're a methodologist, you might want to take small randomized controlled trials and combine them together to try to answer a question. You can do that with a systematic evidence review and ultimately maybe a meta-analysis. You might be interested in understanding if there's evidence, is it cost effective? And can you develop some sort of a guidance from it? What does that mean to people in practice? And then ultimately from this comes this, which is the idea of minimal standards of care. What's the least we should do in a particular circumstance? That's a performance measure, a quality measure. And that defines how care is being delivered and the quality of care. Health services research started with an exploration of variability. And the classic study by Wenberg back in, I think, the 70s and 80s in New England showed that there were dramatically different rates of hysterectomy occurring. And it suggested a quality problem. When you see a lot of variability, it suggests that for some reason people are treating people differently, people are getting different things done. So measuring variations starts the process. And then ultimately where it's gotten even more interesting is how do we improve quality? How do we translate research into practice? And that's implementation science and quality improvement. And I'll talk about how those are similar yet slightly different. So let me start up.
Can I ask you a question?
Please.
Can you say something about the impact on the field and the researchers to have these funding streams that pop up and then disappear? And do you think it makes you be nimble, but is there another harm to the field of having that happen?
I think, yeah, as your question suggests, I think there most certainly is. I mean, people develop infrastructure and then sometimes they can't sustain it. On the other hand, they develop it. And the good news is, and I'll finish with this, but thanks for asking the question now because it really is timely. I think that there's a better recognition. You know, when I got interested in this, gosh, almost 30 years ago, you know, UAB was doing some stuff, but there wasn't a lot going on at a lot of places. And now, through the CTSAs with PCORI, there's a lot more activity. And so NIH is now doing this. Interestingly, now, when you write grants to NIH that might go to a certain study section that historically has maybe been more epidemiology oriented, people reviewing these grants have been part of PCORnet, or they've been part of the PCORI process. And so if you don't have patients engaged, you get dinged. So I mean, there's certain things that have sort of caught on nationally. I don't think those are going to go away. And so I do think you're right that it's difficult. And so, for example, AHRQ, we had a center funded from AHRQ called the CERTS for 17 years. We started it, we ended it, the program went away, but that allowed us to, at UAB, to grow pharmacoepidemiology, to do large database work. So there were some lasting impacts of that initial investment over that period of time from ARC. ARC is now in, in a state of perpetual chaos because they're actually, in essence, a tax on NIH, and they're sort of at the whim of whoever's in congressional leadership at the time. So, yeah, so great question. Let me give some examples. I want to come back to that in the end, and we can talk more about how to get funded in this area and what kinds of things do and don't sell. But so the first set of studies are cohort studies assessing effectiveness and safety of therapeutics. And I'm going to differentiate observational data from interventional data in answering some of these questions. This is just a classic cohort, the Women's Health Initiative. Probably most of you, if not all of you, have heard of the WHO, the Women's Health Initiative, one of the largest cohorts ever done by the NIH. And it was very pivotal because up until the time of this study, there was a pretty widely held perception that estrogen used after menopause was cardioprotective. And WHI showed that among women who happen to be mostly in their 70s, and so that may have some important nuances in terms of how to interpret the data, actually it turned out that not only were they not cardioprotective, but they had an increased risk, so a nearly 30% increased risk of causing coronary heart disease. And you can see the relative risk is significant because it doesn't include one. So we look both at relative risk and we look at absolute risk, which gives us the excess or the reduced risk per some populations. This has a little more public health relevance because it takes into account the prevalence of the condition. And you can see that this was also the first time in a large RCT that we actually showed that estrogen reduced the risk of a bone outcome of hip fractures. And there were 5 per 10,000 fewer hip fractures seen if you were randomized to get estrogen versus not. And other outcomes are shown here as well. So when you see data like this, in this case, an RCT, you might ask the question, is it a real association? Is it true? Is it chance? Is it confounding? Is it bias? This is a particular problem when we use observational data to try to answer questions about efficacy. And I want to just spend a minute, because I'm going to show data, particularly from observational studies, to differentiate bias from confounding. These are terms we use commonly, but they have very specific meaning in epidemiology. Bias is a systematic error in study design or conduct. Confounding is something we can actually, and we can't usually, the only way to fix bias is to design a study to avoid it. There's no adjustment analytically, there's no post hoc way to address it, it's there. But confounding, on the other hand, is this idea of a false association between an exposure and the outcome of interest due to relationship of the exposure and outcome with a third independent factor. The classic example is it appears that alcohol consumption causes lung cancer. That probably doesn't have a physiologic basis, but we know people that drink a lot tend to be more likely to smoke. And so alcohol is confounded, the association is confounded by smoking. Here are some of the ways, particularly in observational studies. I started with an RCT and now I'm moving into, we're going to look at some observational data. Here are some of the ways that we can address confounding. We can address it, first of all, in a randomized controlled trial by assigning people by chance to either get or not get the exposure. And if your study's large enough, you ought to balance things out. You ought to have pretty equal baseline risk factors in those two groups. So that's the strongest design we really have, is randomization. But it's not perfect. And if you have a small study, or if there's some reason that something you didn't think about in a subgroup gets in there, it can be still a problem. But normally randomization works very well at addressing confounding. We can do restriction. If we're very worried about a particular characteristic, we can restrict. We can do matching in the design. And that's something we tend to not like to do in general, because once you match on something, you can't analyze for it further. And those are all things in the design phase, but in the analytic phase, there's a bunch of things that you're probably used to seeing. You can do stratified analysis where you look at subgroups. You can do simple adjustments, or more commonly, what we're used to seeing in most of the biomedical research papers we read is a multivariable adjustment where you use logistic regression or multivariable linear regression or some sort of a Cox proportional hazards model where you analytically account for multiple factors that might be confounding the association. Another approach is using sensitivity analysis, best case and worst case scenarios. So now, as we look at some of the data that I'm going to be sharing with you, we're going to try to decide whether or not, from observational data in particular, there's a causal relationship or there's a trend or a suggestion of causality. Now, in an RCT, well done, large, definitive, you often can say that there is causality. That's something that we can sometimes walk away from that with. In an observational study, it's much more difficult. And Bradford Hill has proposed a number of criteria that we should think about. Strength of association, dose response, consistency with prior observations, temporality, biological plausibility for all the people in the lab or doing more early phase translational research. Does it make biologic sense? Is there a rationale for why this association might be there? And this last one is really quite interesting. I'm a person who is interested in hyperuricemia and gout. And it's great because gout is a wonderful disease to study. We actually have a drug that can reverse gout. It can lower uric acid, which is what causes gout. And if we, for example, think that hyperuricemia, high uric acid, is associated with, say, heart disease or high blood pressure, and we give somebody a medicine to reduce it, can we make that go away? And if we make that go away, that adds credibility to the argument that there's a causal relationship. So these are some of the things we're going to think about. So let's look at some observational data and use some of these principles. Here's a study I did now quite a few years ago, and it asked the question about what side effects occur with steroids, glucocorticoids. And we were interested in all the things that are pretty common. This was a retrospective cohort analysis looking at users of glucocorticoids matched by age, sex, and duration of disease to non-users. I told you that matching is not a very good idea in general, but we did it because the numbers were relatively small. We wanted to have some equivalence in the baseline characteristics. And you can see the different outcomes that might occur. It turned out that among users, having a broken bone, a fracture, was more common if you were on glucocorticoids. And then we looked at dose response. We were interested, was there a dose response relationship? So for the people not on steroids, at 5 years, they had about a 20% chance in this survival analysis of a bad outcome. And compare that with those taking steroids at modest doses, 10 to 15 milligrams a day, they had a nearly 80% chance at 5 years of one of these bad outcomes, here defined as the probability of remaining free of an adverse event. And fractures, again, were at the top of the list. So that suggests potential for dose response. We also did a multivariable analysis where we accounted for the factors that actually associate with worse disease, because people that have worse arthritis are more likely to get treated with steroids. So there's an issue of confounding by indication. And indeed, having worse rheumatoid arthritis was associated with the bad outcome. But even after accounting for these factors analytically, we still saw a dose-response relationship such that if you were up in this upper dose group, you had a 32-fold odds of one of these bad outcomes. So be careful, though, when we look at observational studies of drugs, devices, and biologics, because there is this problem, this selection bias known as confounding by indication. These people in this study were not randomly assigned to receive steroids. They were selected by their clinicians to get steroids, and we know that it's the sicker patients who get treated more aggressively. And while I can analytically adjust for some of the things that we can measure, there's often unmeasured confounders that may limit your ability to differentiate. Moreover, in a cohort study, another bias is a detection bias. that if you follow people in unequal ways, if you don't have systematic follow-up like you would in a clinical trial, you may pick up more events. Maybe the people who had some of the very occult fractures, spine fractures, for example, only a third are detected clinically. Many people just have back pain and suffer through it and don't even know they have it. Maybe if you come to see your doctor more because your arthritis is worse, you're more likely to get an x-ray that showed a fracture. So that's the type of detection bias that we should also worry about when looking at observational studies. So can randomized trials fix the biases of observational studies and address all these questions? And we do have a hierarchy of evidence. We always want to start as high in this hierarchy as we can and try to work our way down. Now, the problem with studying this in an RCT is that it's very costly and it takes a lot of people. You really have to look at thousands of people to be able to pick up. When you design and power a study, you want to be able to pick up an odds ratio or relative risk of maybe 1.5 as your smallest detectable risk. And you can see that we need over 1,300 people, and there just are not studies large enough in this area to address this question. So as a result, we think about other ways we can address the problem. And there's calls from our esteemed lay press publications, USA Today, that we ought to be using databases that are there already. We ought to be using these databases to study this. And so observational studies based on claims data have garnered a lot of interest. You've got all this billing information available. People come in, they get health care. You get records of diagnoses, procedures, prescriptions. This data can all be culled together using administrative codes for drugs. This is now ICD-10, NDC codes for drugs. And all of this lives in big files, such as with Medicare, Medicaid, private sector payers, Blue Cross, Kaiser, Aetna, United Healthcare. These are all groups that we here at UAB have worked with over the years. And we have a group here at UAB called the Peer Group, which is a spin-off of the large ARC Center that we had a few years ago that does this sort of work. They work with large databases, and they do a particular type of epidemiology, pharmacoepidemiology, that typically involves working with large databases. So they have Medicare, they have Medicaid, and you can see some of the other data sets. The VA, by the way, is a terrific source of research data. It's got the true EHR data, and it also has all this administrative data. It's difficult sometimes to get people to know how to use it, and we've had some challenges here at UAB and at the Birmingham VA and maintaining the infrastructure to do the work in our VA EHR data, but it's very powerful. So let me give an example of working with this data around another area in rheumatology, and that's the use of drugs that affect inflammation. One of the molecules, the pro-inflammatory cytokines that cause inflammation and damage in rheumatoid arthritis, is tumor necrosis factor, and there's some really very remarkable therapies targeting this that are monoclonal antibodies and soluble receptor blockers to tumor necrosis factor. And these drugs have now been around for roughly 20 years and have really changed the way people feel and live with diseases like this. In fact, you all know about these even if you're not in the area because they advertise on TV, which is kind of crazy, isn't it, when you think about it? We're talking about diseases collectively, rheumatoid arthritis, psoriasis, psoriatic arthritis, that collectively comprise less than 10% of the population. And yet when you turn on primetime TV, there's an ad for one of these drugs. So they're making a lot of money. In fact, adalimumab Humira is the largest drug in the world in terms of its overall profit. Okay, so these are big business drugs, very efficacious, but also questions about their safety. And the questions that emerged with the safety were the same sorts of questions. Is it the drug that's causing the bad outcome that's seen, or is it that doctors are selectively identifying people to give these drugs to that have worse outcomes? So is it independent risks of the drugs or risks associated with more severe arthritis? Could it be co-therapy such as steroids? In any event, the regulatory agencies, being risk averse, put black box warnings around many of these things. And one of the black box warnings was listed here for kids, and kids get arthritis too. And if you're a parent of a child with arthritis and your doctor says, well, I want to give your child one of these drugs, and you go in on the internet and read this black box warning, it's pretty scary because you certainly don't want your kid to end up with a hematologic malignancy like lymphoma. So our colleague here, Tim Buchelman, who's a pediatric rheumatologist and a very well-trained pharmacoepidemiologist, worked with a large group at Penn with a fellow named Brian Strom, who really was one of the fathers of this field and has a large group at the University of Pennsylvania, looked at Medicaid administrative claims to determine the rate of malignancy among children with this condition and to compare these rates for children not having the juvenile inflammatory arthritis, but having attention deficit disorder as a control group of children seen frequently. And you can see that regrettably having juvenile inflammatory arthritis, because of the immunologic nature of the condition, does have an increased risk of having this compared to kids who don't have it. And so you can see that, and this is methotrexate, another drug commonly used, there was also an increased rate. But if you looked at the kids with juvenile inflammatory arthritis, just on the tumor necrosis factor inhibitors alone, you didn't see any signs of hematologic or other malignancies. Now, again, let's be very cautious in looking at this data because of all the caveats that we've been discussing. But that said, you're not going to find numbers bigger than this in studying this. This is not a common problem. We're talking now about a national sample of Medicaid data. And regrettably, when kids get sick like this, when they develop things like lymphoma, they receive medical care. And so you've got billing data that does indicate that is the outcome. So the point of all this is that if you do this work well, if you use this sort of data, this billing data well, you can actually generate reports that are of considerable national interest. And here's some other examples of work that we've done, all three JAMA publications, looking at this class of medicines, in this case with the risk of developing various infections, including shingles. And these were collaborations across multiple institutions with databases including Medicare, private sector data, Medicaid from Tennessee in particular, and a lot of great investigators, including Jeff Curtis, who you guys should get to know if you're interested in this area, is one of the real leaders nationally in this space. So what can administrative data do well? How can, if you want to ask a question in your particular area and you want to use large databases, you want to use billing data, this gives you a way to do this with great generalizability, with large national resources, and it can complement other approaches at a relatively reasonable cost. Surprisingly, you do, if you want to use Medicare data, you think, well, gosh, that's government data, I should just be able to ask for that and get it. You got to pay for it, and it actually costs a lot of money. And interestingly, when you ask for it, you have to be very specific about what you want to do with it. And if, say, you get Medicare data and your colleague wants to use it, they have to repay for it. They got to put in a new request and get it again. So there's a lot of very interesting idiosyncrasies with using it. We have a lot of experience at UAB in doing this. But there are problems when you use it alone. First of all, there's problems around classification of disease states, exposures, and outcomes. There may be miscoding. And for the clinicians in the room, we're all aware that we see people in the clinic, and sometimes the billing codes that are used don't necessarily reflect what was necessarily the main problem. For things like arthritis, a big challenge is we don't know much about the activity or the severity of the disease state. We don't know how many joints were swollen or what the activity to daily living score was. That's not in there. And it's also sometimes difficult to differentiate whether it's a new or an old problem because there can be censoring on the left if people join Medicare at age 65, say, and they had a problem that started at age 60. We don't know if that's old or new. And we don't have detailed information on comorbidity. So really one of the best scenarios is to have this data, this administrative data, and to link it to some more granular data set like a registry. And in fact, that's what many colleagues have done, is to take a patient registry, a disease registry, to ask people to provide a unique identifier like their social security number, and if it's a condition that affects older adults, for example, to be able to link them to their Medicare data. So I'll give an example in a few minutes, but just to sort of carry that through, we're interested in fractures, and fractures mostly affect older adults. And if you're 65 and older and you break your hip, you get hospitalized. You have to have an operation or you go to the hospital, 98% of the time. And so we're fairly certain that when somebody has an ICD-10 code or a procedure code for a hip fracture, that's a real outcome. And so if we have somebody in a clinical trial and we have a link to their Medicare data, we can follow them almost indefinitely. We can see 10, 20 years later whether or not they've had the outcome that we're interested in. So that gives you a lot of power, because often you lose people to follow up in traditional clinical trials. So there's been a lot of back and forth about, should we do observational studies? Should we rely just on RCTs? Sackett, one of the fathers of epidemiology, says, or evidence-based medicine rather, not epidemiology, as you might see here, suggests that if you find a study was not randomized, we'd suggest you stop reading it and go to the next article. And then more sanguine comments are that we need both observational studies and RCTs because they answer different questions.
Just a question about what you said on the last slide. So when you have these Medicare codes, you can do the follow-up for 10, 20, whatever years.
Mm-hmm.
Do you put that in their informed consent that you will follow up on them for a certain period of time, or do you say forever? How do you put that in?
No, it's a great question. And yeah, you have to tell people what you're going to do when you sign them up. The more challenging part often is getting permission to get their social security number. And we've done that in a variety of studies now. Most people, when they understand what it's for and what the purpose is, are often willing to provide it, but not everybody, as you might expect. But yeah, you have to tell them that you're going to be continuing to follow them.
And then you still have people sign?
Yeah.
Okay.
Yeah. If you explain it well, I mean, but you're right. Every time, and so this is one of the challenges. I want to come back to the idea of a learning healthcare system and some of the issues around sort of pragmatic design and real world effectiveness studies. But yeah, how do you answer some of these questions in the real world? It's a real challenge. Yeah. Another question?
Yeah, I know that kids often will have their primary insurance as one thing, and then their secondary insurance will be Medicaid.
Mm-hmm.
When you pull the Medicaid and Medicare data, if something was billed to their private insurance, does that code show up, or is it only the stuff that Medicaid, Medicare, and that's captured?
Yeah, I'm not. So with children, if they're in the Medicaid program but they have other coverage, I don't know the answer to that, and that's a good question. There's people here that we could talk to that would know that. It's a very interesting question in a number of data sets we work with. One of the real problems we run into, we love to work with VA data because it's such a wonderful data source, but people that are seen at the VA may also get their care elsewhere. And so back to the hip fracture example, if you're in the VA, you come here to the Birmingham VA to get your general medical care, but you live in Selma and you fall down and break your hip, you're going to show up in the Selma ED and get your hip taken care of there. And the VA may or may not know about that for a while, if ever. Maybe it doesn't even make it to your problem list later on. And so, yes, there can be differences and difficulties with incomplete capture. The example you give is a little interesting. For Medicare, it generally doesn't tend to be a problem. I'm more familiar with Medicare data as an adult researcher. But there, everybody, even if you have copay, your data will be there. Now, there's some nuances around pharmacy benefits, Part D, et cetera. Do you have Part D, and are your pharmacy data there? But that's a great issue, and we have to be attentive to those things because you can lose some of the information if you're not careful. Now, John Ioannidis is a medical heretic, and he put this article together really, I think, to generate discussion, but suggests that if you do a large RCT, you've got an 85% chance of finding the truth, whereas if you do a large epi study, you've got 20% chance of finding the truth, okay? And so in support of observational studies is this discordance initially between the fact that all these apparently well-done observational studies suggested that hormones were protective for heart disease initially, and then along came a well-done randomized controlled trial which showed the opposite. But when you go back, and a researcher at Harvard actually went back and used a method called marginal structural models, reanalyzed the data in a very rigorous way, she got the same conclusion as the WHI from some of the earlier studies. So it's about how well and how carefully the observational studies are done. Well-designed observational studies do not systematically overestimate the magnitude of effects, and others suggested little effect, that observational studies were consistently larger or qualitatively different from RCT. So I think the conclusion that I have is that it's not fair to compare good RCTs with bad observational studies. We really need both, and there's a lot of things we simply can't randomize people to do. Anything having to do with behavior. You can't tell people how much to drink or how much to smoke or how much to exercise. I mean, these are things that if you're interested in the impact of any sort of a lifestyle factor, you're stuck with observational data, and it's really much more real world. So we have to do a better job with observational studies using inclusion-exclusion criteria, validating endpoints, and other things to make the work better.
But didn't the researchers or the community think that those observational studies were well done until the RCT was?
That's what they thought,
Yeah.
but methodology improves. And so we have newer approaches to address this issue of confounding by indication. We used to just do, very traditional multivariable analyses. Now we do things like propensity score, matching. We can use instrumental variables. We can use marginal structural models. There's all sorts of new ways to think about how to address this issue of unmeasured confounding. And they're not perfect. They're never going to be perfect. And they're not going to substitute fully for a really well-done randomized RCT. But in certain circumstances, they're better than not. And that's a good segue then to real-world clinical trials. So when we think about clinical trials, we're talking about early phase studies in healthy volunteers, then dose finding, dose escalation to figure out what the right dose should be. Ultimately, most of us who think about clinical trials think about phase 3. This is the regulatory phase to try to get something approved and on the market. But the other phase that's very intriguing is phase 4, aftermarket. And that's mostly what I want to talk about, because this is where comparative effectiveness research, pharmacovigilance, and pharmacoeconomics come into play. And we've seen very important examples of the value of this. The Vioxx story. You remember Vioxx was that anti-inflammatory medicine that was done fairly carefully in RCTs. It turned out there may have been a little bit of messing around with the data, which was quite regrettable. But when it came out, there was a recognition that while it may lower your risk of having GI problems, it actually seemed to increase your risk of having heart attacks. And it wasn't until it was on the market that we knew that. And there's lots and lots of other examples in our history that speak to this. So it is important. And many drugs nowadays get approved by the FDA with a REM package where you have to plan a certain pharmacovigilance. You may have a limited label, a limited indication for who you can give the drug to until this phase 4 work has been done. So we need new ways to do this besides just observational studies. And historically, most studies have not really answered the questions that we're interested in. They've compared drugs to placebo, which is what you need to do to get it approved, but we really want to have head-to-head studies to make clinical decisions. Not all questions can be answered and need to be answered by traditional clinical trials, and traditional clinical trials are typically very expensive and very inefficient. So think about a traditional clinical trial that has very high internal validity, up here, very high internal validity, but very low generalizability. Generalizability is effectiveness. Does it really apply to the real world? Does it apply to the universe of patients? Pragmatic clinical trials have better generalizability, but lower validity. So the pragmatic trials measure real-world effectiveness to differentiate that from efficacy. Efficacy is what you get in phase 3. Effectiveness is real-world. They have often large sample sizes, minimal inclusion criteria, simple treatment regimens, and objective patient-centered outcomes. Those are pragmatic clinical trials. Efficacy versus effectiveness. Traditional clinical trials are done in selected populations. You have a healthy person effect. You may be missing important subgroups of people with certain levels of your disease. Certain demographic groups are often underrepresented. Women historically have been understudied. Underrepresented minorities have been understudied in clinical trials. This is a real limitation of historic clinical trials. And they have very tightly controlled follow-up assessments. You got to come in, you got to see the doctor, you got to have your whatever measured, and people don't, often do everything they're supposed to do. They have very strict protocols. They're very attentive to adherence to therapy. All really important to establish proof of principle. Explanatory studies are what we're talking about, and they tell us whether the new treatment possesses the favorable activity and manner which laboratory studies have led us to suspect. Can it work under ideal circumstances? These are efficacy trials. Pragmatic trials assess the practical value of the new treatment to other existing treatments. Does it work under usual circumstances? Effectiveness trials, management trials, often called large simple trials, although not all pragmatic trials are large and simple, but many are. Let's look at an example. So it's a continuum, it's not a dichotomy. So here's an example of compliance. So an explanatory study, the RCT that would be used for regulatory approval, exclude non-compliant patients before the study. You might have a run-in period where if somebody isn't taking their medicine as they're supposed to, they get kicked out before they get randomized. You could apply a compliance improving strategy to everybody. You might monitor compliance and intervene if it's low. You might only monitor, or in the most pragmatic of designs, you might do nothing. You might just see what happens, because that's what happens in the real world. And that's really what you want to know. If people only take their medicine half the time, that's what you really should be interested in, right? So if you write a grant to PCORI, and there's an RFA for pragmatic clinical trials, you have to put in this figure. And this is a spider diagram that shows you all the different dimensions that you might consider in deciding, is something explanatory or is it pragmatic? And again, it's a continuum across each of these dimensions. So using these spider diagrams, you can see this study is highly pragmatic. Just very simple self-administered versus observed tuberculosis treatment in a population in Africa. This study is almost fully explanatory. This would be a more traditional RCT, and you can look across the different spokes in the wheel and try to make a decision in some sort of a formalized way about where your study fits. Here's a famous pragmatic trial called ALLHAD, looking at antihypertensive treatment and showing for the first time that diuretics, very low-cost blood pressure pills, look pretty similar to more expensive medicines. 8 years, UAB had a quarter of the participants, 42,000 people, certainly a large study, $125 million, okay? Don't think NIH is going to do too many more of these. Some debate about whether it was worth it. Did they learn enough for that price? We designed a study. When you design a study, one of the first things you got to do is come up with a catchy acronym. We're pretty happy with ourselves here. We got a nice, cute little figure here. For the effectiveness of discontinuing bisphosphonates, we got some money for a planning grant and a pilot grant from the NIH. First, the challenges of doing clinical trials are recruitment, enrollment, and getting people to sign up. Those are the three biggest challenges, okay? So recruitment, recruitment, and recruitment. And you got to figure out how to do it. How do you hook people? What is it that gets them interested? And so you develop advertisement materials. A lot of the skills in doing RCTs, particularly ones that might come to you from outside, have nothing to do with anything you ever learned in grad school or med school, but can you advertise? Are you a good salesman? Do you know how to get the word out about the study? We also were interested in trying to think about ways we could overcome some of the barriers to doing studies for people that are not clinical trialists. One of the barriers that we were concerned about was the informed consent process. Because if you're off in a small practice in rural Alabama and you don't have a team of coordinators and you're asking your nurses who are running around like crazy trying to take care of patients to sign people up, wouldn't it be great if this could sort of happen on its own? And so we thought about technology, and we worked with a vendor called Mitris that's now involved with the bigger group to develop a customized iPad application where we had avatars talking about the study. They say that looks like me. I don't think so, though. But the avatars come out and tell you what the study's like. What's going to happen to you if you've been on this medicine for 3 years or more. You're going to get assigned by chance either to stop it or to continue it. And the nice thing about doing it on the iPad is you can quiz people. You can figure out whether they know what they're getting into. And you might decide they don't really understand it and you don't want to include them, or you might need to remediate them. And you can also now, per the new requirements or the new guidances around the IRBs, you can do e-consent. And you can actually have people sign up electronically. Lots of power to this. And you think about some disease states where you could go direct to patients. In fact, there's a large pragmatic trial led by Cohort using a low-dose aspirin, direct-to-patient study to try to figure out whether low-dose aspirin is primary prophylaxis, actually prevents heart attacks. And that study is a direct-to-patient study of tens of thousands of people across many different networks.
What was the acceptability of the patients and the providers in the small areas? I bet it was high.
With this approach, we actually, so I didn't finish the story and I'm about to transition away, so I'll give the punchline here. We actually did go out into the community and we tested all this methodology and people liked it. The doctors in the community were able to use this and look good. The feasibility was fine. We designed the study. Turned out that when we got all done with all that, we gotten this $1 million plus amount of money from NIH through the R21 and the U34 to pilot and plan. We put in the manual of operating procedures. We wrote a letter of intent to the agency. They said, well, you guys have done a great job designing all this, but we don't have $20 million to do your study, which is really, it's a quarter of what the all-hat study costs, but that's still a big price tag. And so the study didn't actually get done. And it turns out that at this point in time with this particular question, it may not be possible to do the study because we've lost equipoise. There's not, people have made a decision, for those familiar with this class of medicine, that bisphosphonates, many people now are taking a break on their own. And so that we've lost the point of equivalence of when people might agree to either stop or continue. So I don't think we'll ever know the answer with an RCT, and we're stuck with observational data. All right, so I mentioned this earlier, this idea of a learning healthcare system. How can we embed these studies in a very simple way in our healthcare system? I think the oncologists have clearly done this the best, haven't they? When you come in and you've got a weird or bad cancer, you almost inevitably get put onto a clinical trial. But how do we do this for so many of the other things we do in practice where we're not sure what to do? We don't know. We might have equipoise around a decision to use a drug or not use a drug, or one versus the other. And so Cass and Faden, two bioethicists at Hopkins, have suggested that there's a moral priority, in fact, a moral imperative, to do this in a systematic way, and that the obligation extends to patients justified by the principle of common good, and that as members of society, we have a common interest in ensuring an affordable, high-quality healthcare system. So this is the sort of bioethical framework for the idea of a learning healthcare environment, where we're using the data, we're using our electronic data, and we're doing universal consenting when people come in, and if they want to participate, they can, and we can follow them long term. Trying to get all that operationalized, particularly at many medical centers, is really a big challenge. All right, so let me, I'm running a little bit long here, but how much time do we have, David?
You go.
Okay. All right. About another 15 or 20 minutes here. So I want to talk about implementation science and go back to this diagram of the conceptual model from basic science knowledge to current clinical knowledge, and this idea of late stage translation, implementation research. This is the Donna Beaton, very famous, very old premise of health services research, that we have somebody in an initial health state and we want to move them to a better health state, and we can do this by changing the process or structure of healthcare to change the outcome. So process, structure, and outcome are the three tenets and the three levers for improving healthcare outcomes. So what is implementation science or outcomes research? It suggests that it's outcomes, not where you live, who you are, that should determine how you get treated. And the variations in practice are often associated with differences in outcomes and are a marker of disparities in care, and that values and preferences must be incorporated. This was a pivotal and disappointing paper that showed that we do a lousy job. When you take minimal acceptable standards of care performance measures across a variety of chronic conditions, many people in the US and internationally are not getting the recommended care. This is an example of the underuse or care gap, looking at beta blockers. It starts off as a bad story and ends as a good one, in that you can look back at when we first discovered beta blockers and how some of the initial biologic data suggested efficacy, and then the studies were done in the 80s. Eugene Braunwald, one of the grandfathers of cardiology, he had the famous cardiology textbook, said this is a good idea, we ought to be doing this. That was 1984. And then it took about 20 years before this became the standard of care, before everybody who has a heart attack got put on a beta blocker. Well, we're doing such a good job now that they've retired the quality measure. There's a ceiling effect. There's no reason to measure it anymore, because 85 to 95% of people get a beta blocker after a heart attack. So there's success ultimately, but after a long period of time. And healthcare quality is a big problem. Most of the traditional focus has been on underuse of therapy. There's an increasing movement around overuse and some misuse and hospital errors that occur. One of the things that we've seen more and more is overuse and how we can do a better job. Many groups in medicine have developed a top 5 list of what are the 5 things in your particular area of practice that are unnecessary and have low value. And then the other thing we've been seeing is the idea of audit feedback and comparison. And keep in mind that when UAB sees this sort of a graphic, the healthcare administrators sure don't like this. They don't like to see that we're doing worse than other health centers in any measure, particularly hospital-acquired infection. And similarly, for those who are clinicians, we often get report cards in the mail. We get something that shows how we're doing in a particular area compared to our peers. So we define healthcare quality as health services for individuals and populations that increase the likelihood of desired outcomes are consistent with current professional knowledge with the following dimensions: efficacy, equity, efficiency, safety, timeliness, and patient-centeredness. Implementation research is the study of methods to promote rapid uptake and improve the health of individuals and populations. It's at the intersection of quality improvement and research. It uses methods from health services and epidemiology and qualitative methods, translation science that goes beyond the bedside. So how does it differ from quality improvement? Why is it not just quality improvement? Quality improvement is local. And if you do rapid cycle quality improvement, you build in a car or whatever it is, you do plan, do SEAC, rapid cycle quality improvement, things get better. It's almost inevitable that things will get better. But can you say what you did, and can you translate what you did to another process, to another system? That's the difference. Implementation science is trying to create generalizable knowledge that shows that something works or doesn't work using rigorously designed studies. So how do we do it? How do we implement evidence? Well, you can give people printed materials, either patients, providers, whoever, and they get smarter, but they don't change their behavior. We can go to lectures. We can give lectures to our colleagues. And again, we change knowledge, but it has very little impact on behavior change and practice change. Things like intensive conferencing works for stuff like smoking cessation, but very cost intensive. Computerized tools. Well, Anybody get a lot of pop-ups on their EHR? You figure out how to turn them off. You know, you start to ignore them. There's a little bit of overload. So trying to figure out where the sweet spot is here is difficult, but very useful. Outreach visits, a particular kind called academic detailing, was developed by Steve Sumarai. Very impactful, but very expensive as well. And then audit feedback, I've given examples of that. I'll talk more about that. Multifaceted, multimodal approaches we thought had been the secret to this, but it turns out the context and engagement may be more important. So why does it fail? It fails at different levels. Why does implementation not work? It mostly doesn't not work for doctors and healthcare providers, not because they don't know, but because there's poorly aligned incentives. There's a mismatch. For patients, it may be more about knowledge, and certainly at the system level, there's a lot of barriers. Here's an example of audit feedback. This was done by UAB colleagues, Katerina Kiefer, Jerome Allison, when they were here before they moved up to UAB North in Worcester, Massachusetts, and started the quantitative sciences department there, which has been very successful. And they developed something called the achievable benchmark of care, where you compared people, in this case with the diabetes example, to the statewide project average and the benchmark, the achievable benchmark, the top 10% of your peers with the Bayesian adjustment for the practice size. And you can see that when you get this sort of a report card and you're not doing so well in certain categories because of how competitive we all are and the fact that we want to do a better job, it tends to influence our behavior. And they showed in this paper published in JAMA that it did work and that we could improve process of care measures for diabetes significantly more so than with traditional audit feedback. And CMS adopted this as the preferred form of audit feedback, the achievable benchmarks of care. But we had a similar problem in osteoporosis, particularly among steroid users, where we knew that the rates of treatment and testing were relatively low. They got a little bit better over time. This is this sort of descriptive phase, this practice pattern variation work, but they weren't improving enough. And so we designed a randomized trial of a behavioral intervention, a cluster randomized trial, where we identified high-risk steroid users. We figured out who their doctors were. We randomized their doctors who we didn't know dynamically on the internet. We needed 150, we got 150. And we looked at baseline rates of testing and treatment for bone density and use of bone medicines. What did we do? Well, we did tailored case-based learning based on principles of adult learning theory. We gave achievable benchmarks of care, which had been shown in diabetes and depression to be efficacious. People could get information that they could download for their patients. They could get online CME. We rolled it out over 6 months to combat decay, and here were the results. In the intent to treat analysis, which is the way you should analyze all clinical trials, it didn't work. We didn't see a significant benefit. When we looked at the doctors who did just what we asked, those who went online and got their feedback and did the cases, we followed the protocol perfectly, we started to see some trends towards some efficacy. So it suggested to us that in this particular type of healthcare state, that targeting the physician and the provider, particularly at a non-teachable moment, might not be the right approach. And so we moved into some other approaches to try to improve quality and to test methods to improve quality. One is the idea of narrative communication, storytelling, testimonials. People relate to people they know, and you turn on the TV, you watch a commercial, do you get engaged? The idea of homophily, similarity between the characters. Does the story bring you in? Can you relate to it? The power of narrative to change belief has never been doubted and has always been feared. So brainwashing, but hopefully for a good purpose. Here was an example of how this worked very nicely. This was done at Cooper Green Hospital just down the block, our local safety net hospital, and Jerome Allison and Tom Houston sat down a group of mostly African-American men in the waiting room. They showed them a somewhat grainy DVD of other mostly African-American men talking about complications of high blood pressure, strokes, heart attacks, other problems, and it was quite impactful in improving their blood pressure. In fact, among those that had the worst blood pressure, the effect was most striking, leading to a paper in Annals of Internal Medicine. So a very nicely done implementation science study looking at the idea of storytelling, narrative communication. Now, another approach is a system approach. let's take a low-tech system approach. In this case, for bone density testing, why don't we let people schedule their own? Why don't we give them a 1-800 number that they can call? And we did this in 2 of the Kaiser systems, Kaiser Northwest in Portland and Kaiser of Georgia. We had large numbers. And you can see that when you got self-referral materials, you had a nice improvement compared to usual care in getting a evidence-based appropriate bone density test if you hadn't previously had one. So it worked well. Interestingly, the addition of the storytelling materials didn't add any added value to it. So that was curious, but we're still learning more about that. So just to summarize what we've learned over the years and others have, that first you have to define quality. We have an increasing armamentarium of approaches. Implementation research is truly a team exercise. We have behavioralists, we have clinicians, we have epidemiologists, qualitative researchers. It's not easy to do at a community level. Technology offers us promises. Theory-based creativity is key. One size fits none. Approaches must be tested. And here's why. Because when you look at historic quality improvement without a control group, things look great. Uncontrolled studies, 80% positive, but when you actually do a control, often you get a very different answer. And there may be temporal things going on that you're not aware of. So let me just conclude with a couple comments. We've had a little bit of this discussion already about some funding sources. We talked about PCORI. I mentioned AHRQ, which does accept some grants still, both R01s and otherwise. The VA Health Services and Research Department, foundations, pharma. My colleagues in Jeff Curtis's group have had quite a good experience working with the private sector to do pharmacovigilance. There's been some phenomenal spin-offs of that work, philanthropy, and I guess the NIH is up here. I skipped over that, but the NIH, I think, is catching on more and more to this, and there's more and more opportunities. If you're interested in this sort of work, many of us here would be delighted to talk with you and think about projects that we could do. We could support your work through our T&K program internally and hopefully help you get extramural support either at the training level or as an independent investigator. Many professional societies exist with an interest in different facets of this work. Academy Health is the premier health services research meeting. ISPE is the International Society of Pharmacoepi, a very rigorous meeting, wonderful for learning new methods. Society of Medical Decision Making, Society of General Internal Medicine, all really top-tier meetings for getting more savvy methodologically. And I think I've alluded to some of this already, and David mentioned a few of these things. So I'll stop there and see if there's any other questions, but thank you for bringing some things up as we went along. Any questions about any of these topics? Very good. David?
Okay. Well, thanks very much, Ken. And just for people who came in a little later, who joined online late, I just want to let you know that we will be sending out the first draft of our schedule for your oral presentations. I'm anticipating that we'll have assigned a few people things that won't work for them. So please look at it right away and let us know if there are things that don't work. If there are, please look at all the available times that are on the list and let us know which ones could work for you, and we will do everything we can to put it together. So thanks very much.